This is Jason Vanstone. I am the research scientist with the Stewardship and Clinical Appropriateness Program, under which falls our Antimicrobial Stewardship Program. On the slide here, you can see a number of the core team from our Antimicrobial Stewardship Program. Of course, this is something that reaches out. We have lots of collaborators throughout the health system that we work with, but in Regina here, this is some of our core team. If you're looking for some names to connect with following this presentation. So the purpose of today's presentation is to talk about some of the reasons that we want nurses to be involved in antimicrobial stewardship and try and hopefully point out why in both your personal and professional lives, antimicrobial stewardship should be an important topic to you. So I always like to start with sort of the big picture, and the big picture here is that we have a problem all around the globe. And of course, we have lots of problems all around the globe, but the one that I want to talk about specifically has to do with back in 2016, the United Nations actually held a General Assembly about this topic, and it's a health topic. And it was only the fourth time in the history of that body that they had had an assembly around a health topic. So it is something that is very important worldwide and has caught the attention of these international bodies who are trying to help take strides towards fixing this problem. And so the problem that I'm talking about is antibiotic resistance. So just to put that in context, we can ask the question, what is antibiotic resistance? So if you have your regular run-of-the-mill bacterium, like this guy here, these are the types of bacteria that when we throw antibiotics at them, those bacteria die. They get killed by whatever mechanisms the antibiotics use to kill those bacteria. When we talk about antibiotic resistance, we're talking about superbugs. So these are bacteria who have essentially evolved genetic mechanisms to be resistant to antibiotics. So you've got a bacterium that has some kind of genetic gene that it has acquired that allows it to be resistant to those effects of the antibiotics. So the antibiotics can no longer kill those bacteria. And so this is all antibiotic resistance is. It's a genetic trait, and it allows these bacteria to be resistant to those medicines that we would normally use to kill them. And that, of course, makes them kind of a nuisance to human medicine because it means we can no longer use antibiotics to kill these bacteria, which we once could. So that poses a big problem for a lot of areas of medicine. One important point is to understand what drives antibiotic resistance. So how does this occur? We know now it's a genetic trait, and what causes it to happen. So one of the most important things is about how we use antibiotics. So here in this graph, we're looking at the months of the year across the bottom, going from January through December. And the blue part of the graph here shows the penicillin prescriptions. This is data. This was a study that was done in the States. So if you look in the wintertime, we see high numbers of antibiotic prescriptions. And that sort of decreases as we go into the summer months. And then school starts up again, and flu season comes around, and everyone's congregating together, and more people are getting sick, and they're going back to their doctors, and we're seeing increases in the use of antibiotics. And so what they did in this study is they compared this with the resistance to that antibiotic in this case, E. coli bacteria. And so you can see that when there's a peak of high usage in antibiotics, there's about a 1 month lag, but we then see this peak in resistance to that antibiotic. And then as we use fewer antibiotics, we see less resistance. And then when we start to use more antibiotics, we see more resistance in those bacteria. So we know from data like this that the more antibiotics we use, the more antibiotic-resistant bacteria we will see. So it's our own use of antibiotics that drives this resistance. And in the local context here in Saskatchewan, the latest data that we have from some of our national bodies like the Public Health Agency and the Canadian Antimicrobial Resistance Surveillance System, so this was from their 2018 report, and it showed that across the country, Saskatchewan was the second highest user of community prescribed antimicrobials. So when we go to our family doctor or perhaps nurse practitioner in the community, or if you're getting an outpatient prescription from an emergency room, that's what's being counted here. So for all different types of antibiotics and antifungals and antivirals that are being prescribed. And so across the country, in Saskatchewan, we are the second highest user based on our population. And this has been consistent over a number of years, and so there's no reason to believe that has changed in the last couple of years. And to me, this is something that highlights that we have room to improve our use, the appropriateness of our use of antibiotics in this province. So I want to talk briefly about what is antimicrobial stewardship in a clinical sense. So what does this mean for clinicians? How do you do antimicrobial stewardship when you're dealing with patients? And so we kind of sum this up into about 5 questions. The first question is an antibiotic necessary? So you have to ask yourself if the patient is even going to benefit from an antibiotic. Do they even have a bacterial infection? That's the only reason you would need to use an antibiotic. If they do have a bacterial infection, then, all right, let's find out which drug we want to use, and we want to make sure we're using the right drug, the right dose, the right duration of treatment, and the right route. So I'm going to talk about each of those 5 questions in a little more detail. So the first question of, is an antibiotic necessary? And to answer that, we really need to understand the difference between bacteria and viruses and how antibiotics work. So here is your typical bacterial cell. You've got plasma membrane and cell walls. They've got DNA inside. They've got little machines, little biological machines that make their proteins and things like that. That's a bacteria. It's all one living thing, all complete inside one cell. You compare that to a virus. Viruses are essentially just DNA or RNA, some kind of nucleic acid, inside some kind of a protein shell. Might have sort of that layer on it. But that's essentially it. So they don't have any of these proteins and things that are used in the bacteria to replicate the DNA, to create their own proteins for their shell and stuff like that. The viruses survive by infecting a host and using that host machinery to make more of themselves, whereas bacteria are a self-contained living system. And so when we talk about antibiotics, antibiotics work by affecting the ability of living things to create their own proteins, to replicate their own DNA, and things like that. And that is why, if you have a bacterial infection, antibiotics work against bacteria, but a viral infection will not respond to the use of antibiotics. So because these antibiotics don't target anything that the virus has, they will not work on it. And so, again, another study from the CDC in the United States, we know that this is not appropriate. We should not be treating viral illnesses with antibiotics. And yet, from their study, at least 30% of their outpatient prescriptions were unnecessary. So at least 30%, that was their low-end estimate, and it could be as high as 50%. And when we're talking unnecessary, what that means is they were looking at things like antibiotics that were being used for viral illnesses or to treat asthma, different things like that. Things where there is zero indication and evidence for antibiotic use. So if you consider that, at least 1 in every 3 antibiotic prescriptions is unnecessary. There's huge room for improvement if we're simply not prescribing for those types of indications. And then for that remaining sort of 50 to 70% of prescriptions, there's still room to improve on the picking the right drug, ensuring that you're getting the right dose and the right duration of treatment. So to speak more to, is it the right drug? So there are different types of antibiotics, and they can be sort of broadly classified into narrow spectrum or broad spectrum antibiotics. Narrow spectrum antibiotics are those that will affect maybe a single type of bacteria or only a few types of bacteria. So they're very targeted in their treatment of the types of bacteria. You can compare those to broad spectrum antibiotics, which could kill many different types of bacteria. And so when we think about that, in terms of treatment, and in terms of the evidence, it is better to be treating people with a narrow spectrum antibiotic, of course, identified what the bacterium is that is causing the infection, so that you are leaving the rest of the bacteria alone. And when we think about this in terms of the human microbiome, the bacteria that live inside and there are lots of good bacteria, those probiotics that live within us and help us digest them. And so if we're taking a broad spectrum antibiotic, not only are we going to kill the bacteria that is infecting us and causing an infection, but we're also going to start to wipe out some of those good bacteria as well. So it's always better to be on a narrow spectrum versus a broad spectrum. The other piece is that broad spectrum antibiotics tend to have side effects where they can increase things like your chance of getting C. difficile. So Clostridioides difficile is a type of bacterium that can, it's very difficult to take out. It's a spore-forming bacteria, so it's a very difficult infection to get rid of. And it creates very intense and painful diarrhea and can kill people. People can die from this. So it's something that you definitely don't want to be exposing yourself to, particularly if you. And I like the analogy from The Matrix. If anyone's seen The Matrix, would you rather have the red pill or the blue pill? In this case, I think most of us would choose that narrow spectrum antibiotic if we had the option. So to move on to the right dose, a lot of what we're going to talk about is refer to the Goldilocks zone, right? So Goldilocks, there was the porridge that was too hot, the porridge that was too cold, and then the just right stuff, the chair that was too hard, the chair that was too soft, and then the chair that was too hard. So a lot of antimicrobial dosing and treatment comes down to finding that Goldilocks zone. So when we're talking about the right dose, obviously, hopefully it's obvious, having much of an antibiotic is a bad thing. That can be harmful not just to the bacteria, but it can also hurt people. So we don't want to have too high of a dose. If you don't have a high enough dose, then you're potentially not killing the bacteria that you are intending to. And so you can get these bacteria can continue growing inside of you, and you're not actually taking out the infection. So what we're looking for is that happy medium, right? The Goldilocks zone where we have enough of a high enough dose to kill the bacteria, not so high that we're harming our patient. And one very good example of that is vancomycin. So that's an antibiotic that we use a lot in the hospital, but it comes with its own side effects. One of those is nephrotoxicity. So it can actually be quite harmful to the kidneys. So in our hospitals, I believe it's often the pharmacists who are monitoring the levels of vancomycin in patients so that they can be constantly adjusting the dose that's being given so that it's not building up too much in the body and causing harm to their kidneys while we're trying to manage their infection. So again, just an example of where we're trying to find that Goldilocks zone of the right dose. And that one's pretty obvious for most people. Most people get the concept of it. One that has become a little bit harder and has been under a lot more scrutiny in recent years is getting the right duration. And so there's a lot of talk about this because people talk about taking your entire length of your prescription. And while that still stands, the question is, what should the length of the prescription be? So if we consider someone who has, for example, a urinary tract, and it's otherwise an uncomplicated case, there's nothing else going on, it's an otherwise healthy individual, they just have some bacteria in their urine that are causing symptoms of an infection. So the goal with treatment is to reduce the number of bacteria, eliminate the bacteria that are causing it. So we start treating that patient, they get their antibiotic, and over a number of days, 5 days here, we see that we've taken a high number of bacteria and reduced them down to basically nothing, to the point where the body's immune system can hopefully take over and clean up anything that's left. What we tend to see, and what's particularly troubling with basic, these sort of uncomplicated infections, is that people tend to continue that treatment, or clinicians will tend to continue those treatments for maybe 7 days or even up to 10 days. And so you're getting more antibiotic than you need because you've already finished off the bacteria here. And so you're simply exposing the body to that antibiotic and those potential side effects from that antibiotic for longer than is needed. And as I talked about with antibiotic resistance, you also have the potential of increasing the number of antibiotic resistant bacteria the longer that you're exposing those bacteria to this antibiotic, particularly when you hit this unnecessary side. So again, we're looking for that Goldilocks zone. You want enough days of treatment that you can eliminate the bad bacteria without exposing patients to those potential side effects. So that's another important one, and it's something we talk about a lot in the world of antimicrobial stewardship. And then the last piece is talking about the right dose, right route. So a lot of patients are started on IV when they come into the hospital, usually because they're quite sick, and so we need to get something in them into the bloodstream fast. We want to ensure that it's getting there. So they'll get started on an IV antibiotic, and which is great that we have access to that. One of the things to consider is that these can take a lot more nursing time because you're going in and switching on IV bags, and they tend to be more expensive. You're using other supplies, you've got generally more expensive drugs, but they have their uses, certainly. One of the things in the world of antimicrobial stewardship is ensuring that as soon as possible, we're getting patients switched from IV to an oral alternative so that, number one, it's safer for the patient because they're not sitting with an IV in their arm, which is a potential port of infection. It does save money. That's not the purpose of antimicrobial stewardship and switching patients, but it is cheaper. And so when we're talking about stewards of the healthcare system and ensuring that our healthcare resources are used wisely, if we can have patients on a cheaper medication, then we should. And of course, in terms of nursing time, it's much easier to just hand a patient a pill for them to take rather than having to switch on IV bags and all that. So that's something that's also important to consider when you're looking at antimicrobials. So I just want to bring this back then to what is the nurse's role in antimicrobial stewardship. And people actually research this stuff. So I've got a couple examples here. This is something I took from a paper that's almost 10 years old now. And it's called Covering More Territory to Fight Resistance, Considering the Nurse's Role. And they had this table in the paper, which kind of covers a lot of stuff that I've already said. So, you know, nurses can become aware of, you know, the different aspects of managing the antibiotics here. So treatment specificity, using narrow spectrum antibiotics versus broad spectrum antibiotics, the duration, ensuring that patients are being taken off those antibiotics as soon as is possible, ensuring they're getting the proper route, knowing the best practice around surgical prophylaxis, those kinds of things. So there's a lot of different pieces that are listed there that I've already sort of talked about. Another paper that I like is the critical role of the staff nurse. The key point here is unrecognized but already there. So they had this really neat table that showed, so you've got nursing, microbiology, case management, pharmacy, et cetera, all the different sort of people in the hospital system that would be working with a patient from their admission to the hospital for their infection all the way to discharge. And so you can see here that they've got a dot beside every part that is relevant to the different players here. And so nursing has a dot on every single one. So the point here is that nurses are very involved in antimicrobial stewardship, even though they may not recognize what they're doing as antimicrobial. But it's things from, you know, triaging and appropriate isolation when that patient comes in, understanding their allergy history, getting early and appropriate cultures, starting the antibiotic at the right time. Like those pieces right there are antimicrobial stewardship. Monitoring the progress of that patient, reporting it back to the rest of the care team, looking at those preliminary micro results and adjusting the antibiotic, and so on and so forth. So one of the pieces we like to highlight is that as nurses, you're probably already doing a lot of the things that are relevant to antimicrobial stewardship. It's just a matter of recognizing where those pieces are. So I mentioned Lorraine at the beginning. She was the nurse who was doing her internship with the provincial government here, and so she got connected to us because she was interested in working in the world of antimicrobial stewardship. And so she did an analysis looking at some of the common barriers for nurses. So she talked to nurse educators and people around our might be what it is that is sort of preventing nurses from engaging fully in it. They're just not familiar with say those words. And so hopefully now, for anyone who's watched this presentation, is familiar with what antimicrobial stewardship is, hopefully why. Antimicrobial stewardship is not in their scope or function because they are not prescribers. And I think one of the pieces I like to highlight here is that we're talking about a prescribing team, right? And a circle of care and all those things. And so it's not just any one person's responsibility for all of the different pieces or any of the one even individual pieces of that pathway. So nurses can ask those questions. Even if you're not the one prescribing, you can ask the questions of the prescriber. You know, is this the right drug? Hey, have we reviewed the microbiology results? Hey, the symptoms seem to be improving. What do we think about the length of therapy? Can they, can we reduce how long on this antibiotic? Those types of things. And Lorraine made the case too that for nurses, when you're got your own license, so if you have questions about the treatment of a patient, it is really within your, you really should be asking those questions, ensuring that patients are getting support. Not being confident about their antibiotic use. So I think the difficult one here is this is hard to present in a 20-minute. I mean, there are entire courses that you can. So this is something where we need to work with nursing programs and things like that to ensure that they are being able to add these things into nursing curriculum so that they can ensure that people are getting more education about this, so they can come out more confident about knowing what to do. And again, part of that is just asking the questions of the care team that you're working with to learn more on them. The last piece then was a lack of awareness about the negative effects of inappropriate use of antibiotics. So this idea that antibiotics cure, right? And that's kind of how people think about this, right? We have these drugs that we should be using to treat people because they help them. And people don't often think about some of those side effects and the negative effects and things like antibiotic resistance. So hopefully, again, this presentation sort of puts that into people's forebrain when they're thinking about the use of antibiotics. All right, so I will stop there. If anyone has any questions after viewing this presentation, they can certainly check out our website there and send us email. The email is listed at the bottom there. And we will be able to answer any questions that you send our way.